بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we are continuing the series of pediatric imaging, and we are now in the fourth lecture concerning imaging of the pediatric chest. You remember in the first part of this pediatric chest, we have discussed the normal anatomy and the techniques. In the second part, we discussed the focal pulmonary lesions, including the nodules and the masses. In the third part, we discussed the remaining focal lung lesions, including the patches and the cavities. Now we will have the final part in the imaging of the lung, which is the unilateral lung pathology. And under this category, we are going to discuss the issues of congenital lung aplasia and congenital hypoplasia of the lung, congenital lobar emphysema, cystic adenomatoid malformation of the lung, Macleod syndrome, and finally we'll have some words about foreign body annihilation, which was discussed in details during the previous three parts. Now, lung aplasia and actually cannot be accurately diagnosed from the plain X-ray of the chest. And here you see that the left hemithorax is totally opaque. You cannot see the cardiac shadow, which is displaced to the left side. And you see that the right lung is good with normal pulmonary vascularity, and this may lead to feel that there is some hypoplasia or even aplasia of the left lung. We can confirm this by ultrasound sometimes, and we can also confirm by CT scan. And here you can see that the mediastinal vessels as well as the heart are seen occupying the left hemithorax. And very importantly, you see this is the main pulmonary artery, and this is the right main branch, which is normal. And you cannot see the left main branch, which is totally aplastic. And this is aplasia of the lung with somewhat compensatory hyperinflation of the right lung. Then you know the aplasia from the hypoplasia by the vascularity, and in cases of aplasia you cannot see any pulmonary vessels on the side of the aplastic lung. And this is another example by CT for a aplastic right lung. You see the left lung is hyperinflated. It is seen crossing the mediastinal border, and the right hemithorax is occupied by the mediastinal vessels as well as the heart. In this example, you can see the trachea and the left main bronchus, which is good, showing the normal bronchi, but the right main bronchus is atretic or aplastic. As you can see, there are no bronchial divisions to the right lung. Then in this example, you look to the CT scans of the chest, and you can see that there is a lung which is relatively small and another lung which is relatively large. And the cardiac shadow is a little bit deviated to the right side. And whenever you see discrepancy in the size of the lung, usually go to evaluate the pulmonary vasculature. And if you look here, then you see that the vascular markings are normal. And if you look in the right lung, you see also that the vascular markings are normal. Then whenever the lung markings or the pulmonary vessels are normal on both sides, then the small side is the abnormal one. Then they consider this lung is abnormal, and now you are going to diagnose a lung hypoplasia. Look at this example, and you see this is the left lung, and the right lung is not well aerated, similar to the left lung. The heart is displaced to the right side. This may be due to hypoplasia of the right lung or hyperinflation of the left lung. Then, if you have the CT scan and you can see vessels normally in the left lung and also vessels which are normally seen in the right lung, then you consider the small lung is the abnormal one, and here you are diagnosing hypoplasia of the right lung. Then we came to a common issue seen in the pediatric age group, and this is congenital lobar emphysema, which means that there is progressive overinflation or hyperinflation of a lobe of the lung, which is commonly the left upper lobe, but it can affect the right upper lobe and can affect other lobes, but the upper lobes are commonly affected, and this hyperinflation is due to obstruction leading to air trapping and consequent enlargement of the affected lobe, and this lobe will compress the remaining part of the lung on the same side and may cross the mediastinum to compress the opposite lung. Then one of the major diagnostic landmarks for congenital lobar emphysema is that you can see the emphysematous lobe is crossing the mediastinal border to the opposite side. And number two, and you see the remaining part of the lung is compressed near the diaphragm. Then, and if you see these two important findings, then you are diagnosing congenital left upper lobe emphysema. And this will need to be differentiated from pneumothorax and other conditions, as I will mention now. Then this condition affects the left upper lobe commonly in about 45% of cases, the middle lobe in about 30% of cases, the right upper lobe 20% of cases, and it may affect two lobes in about 5% of cases. Then for the diagnosis of congenital lobar emphysema, you should see that the emphysematous lobe is crossing the mediastinal border to the opposite side. The remaining part of the lung is compressed towards the diaphragm. And here you see this is an emphysematous lobe crossing the midline to the opposite side. There is compression of the remaining lung near to the diaphragm, with consequent shift of the heart and the mediastinum to the opposite side. If you look to the CT scan and you see that there is a small lung and an enlarged lung, then look to the vascularity. This is the normal vascularity, and there are here scanty vessels. And the lung with abnormal vascularity is the abnormal lung. But if the vascularity is normal on both sides, then the smaller lung is the abnormal one. And this is a hyperinflated upper lobe with scanty pulmonary vasculature, diagnostic of congenital right upper lobe emphysema. And there is another example, and you see the emphysematous lobe is crossing the mediastinal border. The remaining part of the lung is compressed near the diaphragm, and by CT scan you see the scanty vessels in the emphysematous lobe, the normal vessels in the sound lobe. And another example of congenital lobar emphysema of the left upper lobe, which is the commonest site. You see the emphysematous lobe, you see this margin which is crossing towards the opposite side. You see this opacity which represents the compressed lower lobe, and that there is some shift of the mediastinum and heart to the opposite side. The CT scan showed hyperinflated lobe with scanty pulmonary vessels. Then you may have the facility of reconstruction or reformatted images by the multi-detector CT, and here you can appreciate very good the emphysematous left upper lobe, the compressed left lower lobe, and you also see the scanty pulmonary vessels. And sometimes you can have this reformatted image in a 3D way, showing hyperinflated emphysematous right upper lobe, and this is the normal left lung, and this is the compressed remaining part of the right lung. Then we came to the pneumothorax, and the pneumothorax means that there is excess air in the pleural cavity compressing the lung, and in this condition the compressed lung will collapse towards the hilum, and this is very important. The collapsed lung will not compress towards the diaphragm, it will collapse towards the hilum. And here you see the normal pulmonary vessels, and here you do not see any of the vascular markings. This is just hyper translucent hemothorax with the collapsed lung towards the hilum. And here another example. This is the partially collapsed lung, and this is the pleural cavity filled with air. There is some displacement of the heart to the opposite side. And you remember in the course of pneumonic consolidation, sometimes during the healing process of pneumonia, especially the staph pneumonia, there may be some development of nematoceles, which are thin-walled, air-filled cavities within the lung. And sometimes these nematoceles may rupture to form a pneumothorax like this. And then this is the start of the disease, pneumonic consolidation on the left side, then followed by the formation of a nematocele, and this nematocele has been ruptured, forming a pneumothorax which is compressing the underlying lung. Then we have to discriminate between tension pneumothorax and the ordinary or regular pneumothorax. In tension pneumothorax, we should have two specific findings for the diagnosis of tension pneumothorax, and these are: number one, contralateral shift of the mediastinal structures, and number two is flattening and compression of the diaphragm. And you see here that there is a big amount of air within the pleural cavity compressing the underlying lung, but the heart and the mediastinum are shifted to the left side, and the diaphragm is markedly depressed. Then you know they are dealing with a tension pneumothorax. Then we came to one of these lesions which affect the lung unilaterally, which is the McLeod syndrome or the Seward-James lung. This is a lesion which will result in relative hypertranslucency and decreased vascularity of one of the lungs. And this is found to be the sequelae of viral infection early in the lung, and it may present in adulthood. And in many cases, it was found to be the sequelae or just a form of bronchiolitis obliterans. And by time, the affected lung may develop some bronchiectatic changes. The findings are one of the lungs, maybe the left or the right, is relatively hyper translucent compared to the opposite one, with appreciable decrease of the vascular markings and also hypoplasia of the pulmonary artery of the affected lung, and you may get some bronchiectatic changes. And here you see that this lung is relatively hypertranslucent compared to this one, and the vascular markings on the left side are scanty. Then you consider that this lung is abnormal, and this is the 3D reformatted image showing um, the pulmonary vasculature and the bronchial distribution in a patient with McLeod syndrome on the left lung, and you can appreciate the decreased vascular markings on the affected left side. And here, the affected side is the right one. This is the normal pulmonary artery with normal branches, and this is the small pulmonary artery with scanty branches. And the CT scan showed that the vascular markings are good on the left side. They are scanty on the right side with hypoplasia of the pulmonary artery compared to the left one. And the lung window images showed the presence of bronchiectatic changes as well. And this is also an example. And you see the left lung is relatively hypertranslucent with small vessels compared to the right one. The CT scan showed that the left pulmonary artery is relatively hypoplastic compared to the right one, and the lung field is more hypertranslucent compared to the right lung, and you also see the cystic bronchiectatic changes in the left lower lobe. In the foreign body inhalation, as I have mentioned before, can appear in the chest X-ray by many presentations. The first and the most common is the normal chest X-ray, which is seen in about 1/3 of the cases. And the second common finding is the presence of air trapping, where you can see that one lung is hyperinflated and the heart and the mediastinum may be shifted to the opposite side. And this is one of the common findings, and it is diagnostic if you have the clinical support of suspected inhaled foreign body. Also, the presence of consolidation and atelectasis are one of the manifestations for foreign body inhalation, and sometimes you can detect the foreign body itself because of its radio opacity. And here is the hyperinflated left lung, and if you have the chance to have an inspiratory film and an expiratory film, it is good so that you can be sure that there is air trap. And air trap is one of the manifestations or good findings in the chest X-ray to support your diagnosis of foreign body inhalation. By air trap, we mean that the lung does not collapse or deflate during expiration. During inspiration, the air will go into the lung, and during expiration, the bronchus will collapse on the foreign body, preventing air from going outside the lung. Then you got persistent hyperinflation during expiration, and this is diagnostic. It is commonly seen on the right side because the right main bronchus is more online with the trachea, but sometimes you can see the foreign body on the left side, as you can see in this case. And here you may suspect that the foreign body is on the left side, and this is true. This is the foreign body, which is a peanut present within the left main bronchus. There is some atelectasis and consolidation in the left lower lobe. Then we came to one of the lesions seen in the pediatric age group, which is known as the cystic adenomatoid malformation of the lung, which is a congenital disease affecting one of the lungs in the form of hamartomatous proliferation of the terminal bronchioles. And this will result, as you can see in this example, in excessive enlargement of one of the lungs, or maybe one lobe of a lung or the whole lung, and this will lead to compression and displacement of the heart and the mediastinum to the opposite side. The cause of this hamartomatous proliferation is unknown, and it represents this disease about 25% of all congenital lung malformations. It presents during infancy. This is a congenital disease, but it can be seen at any age if the lesion is small. The common presenting symptom is respiratory distress and sometimes recurrent chest infection. Commonly, in the chest X-ray, you will see multiple air-filled cystic lesions affecting the whole of a lung or part of a lung. Then, as you can see here, it can affect a lobe or can affect the whole lung. The affected lobe or the lung will be enlarged, leading to mediastinal shift and the compression of the opposite lung. And if you look carefully here, and you see multiple air-containing cavities within the right lung field. Then the CT scan confirmed the presence of thick wall air-filled cavities compressing the remaining part of the lung and displacing the heart to the opposite side. You should remember that this is a congenital disease and it is diagnosed even in utero, and this is completely different from the issue I have discussed before, which is known as cavitary necrosis complicating pneumonia. This pneumonia is not congenital, and the signs of infection are present, and the patient is sound before the onset of the disease. Then you see here a lesion which is formed of multiple cystic air-filled spaces within the right hemithorax. Then you are suspecting the possibility of congenital cystic adenomatoid malformation of the lung. The CT scans with coronal and sagittal reformatted images confirmed the presence of a lesion which is made of thick wall air-filled cavities affecting part of the right lung, which is the right lower lobe, and there is enlargement of the affected lung with shift of the mediastinum to the opposite side. We have three types of congenital cystic adenomatoid malformation of the lung. In the type 1, which is common and is seen in the clinical practice where the cysts are sizable. In type 2, the cysts are relatively small, and in type 3, the cysts are minute. And this is very difficult to be diagnosed in the clinical practice, but this one is commonly seen and easily diagnosed. The disease, as I have mentioned, can be diagnosed prenatally by ultrasound or by MRI. And this is a classic appearance of cystic adenomatoid malformation affecting the right upper lobe. You see cavities in the right lung by chest X-ray. The cavities that are filled with air are confined to the right upper lobe, and this is because the cavities are sizable, and this is type 1 congenital adenomatoid malformation. One of the very common lesions that are frequently mistaken for congenital cystic anematoid malformation of the lung is the diaphragmatic hernia. The hernia is far common compared to the cystic adenomatoid malformation of the lung. Then, congenital diaphragmatic hernia is also diagnosed in utero, and the patient is usually distressed, and the chest X-ray will show multiple air-filled cavities in one of the hemithoraxes. Then how can you differentiate between both? One of the differentiating points is to see that air in the lung is continuous with air in the abdomen. And in cases of adenomatoid malformation, air loculi in the lung will stop at the level of the diaphragm. And the second way to differentiate is to give the patient barium, either for the upper GI or for the lower GI. And whenever you inject barium or give barium in the colon or by the oral way, then you can see that barium or let us say gastrografin sometimes will go inside the lesion which is located in the chest, confirming the diagnosis of diaphragmatic hernia. Then, if you see multiple air-filled loculi in the hemithorax of an infant or a child, think first of diaphragmatic hernia because it is common or more common. Then, to confirm the diagnosis, you can use ultrasound and you can give barium. If you give barium from above and the lesion did not fill with barium, then you give barium from the rectum and the lesion did not fill with barium. Then the diagnosis will be cystic adenomatoid malformation of the lung. One of the easiest ways to separate both is to have simple CT scan of the chest without contrast injection. Then you can see the bowel loops with their characteristic appearance, and also you can see the cystic spaces of adenomatoid malformation with characteristic appearance. Thank you very much. Alhamdulillah Rabbil Alamin.